Imagine paying like over $1,000 for a cosmetic dermal filler, fully expecting it to last for a year. But instead, your body metabolizes it, and it just completely disappears in less than 3 weeks.
Oh, wow. Yeah, that is incredibly frustrating.
Right. Or consider the terrifying opposite. The filler migrates from your cheekbones all the way down to your jaw, turns into this thick glue-like substance in your tissues, and stays trapped there for a decade.
Which is pretty much a nightmare scenario for anyone.
It really is. And, if you're stepping into a med spa for a routine treatment, you probably assume these are super rare worst-case scenarios. But if your joints click every time you walk up the stairs, or if you've ever been told you're, like, double jointed, you are actually playing by a totally different set of biological rules.
You really are. I mean, the entire aesthetic industry operates on this standardized blueprint of human anatomy.
Right, a baseline.
Exactly. But when a patient has a connective tissue disorder, that foundational blueprint is completely altered. So the expected outcomes they simply do not apply.
Which brings us to the actual mission of today's deep dive. For people with hypermobility or Ehlers-Danlos syndrome, which we're just going to refer to as EDS today, navigating the world of aesthetic and medical treatments is, frankly, an absolute minefield.
It's terrifying for a lot of patients.
Oh, absolutely. So specifically, we are tackling a really heavily debated question today. We're looking at non-surgical procedures. Are dermal fillers actually safer than energy-based devices, like lasers and radiofrequency, for hypermobile patients?
The stakes are incredibly high here, and the conclusions we've drawn from the data today are going to challenge a lot of, conventional medical wisdom.
Yeah, we really had to pull from a massive stack of sources to figure this out. We're looking at clinical guidelines from the EDS clinic, official FDA safety communications, some really dense dermatological abstracts from the EADV Congress.
Those were a heavy read.
They really were.
Yeah.
And we also looked at physical therapy manuals, and we're combining all of that clinical data with real-world patient experiences that we gathered from Reddit forums.
And we have to cast that wide net, right? Because clinical trials for cosmetic procedures, they basically routinely exclude patients with systemic connective tissue disorders.
Oh, because they're seen as too high risk for the trial.
Exactly. So to get an accurate picture of the risk, we have to synthesize the raw clinical mechanics with the actual lived reality of these patients.
Okay, so let's unpack this to really grasp why, a laser or a filler behaves so bizarrely in this population. We have to look at the foundation first.
The collagen.
Yes, the collagen.
Yeah.
EDS and hypermobility spectrum disorders are characterized by a genetic mutation in how the body produces or processes collagen.
And I mean, collagen is the body's most abundant protein. It's the structural scaffolding of literally everything. Your skin, your joints, your tendons.
Blood vessels, right?
Yeah, blood vessels, and even the connective tissue wrapping around your internal organs. So in a healthy body, these collagen fibers cross-link really tightly, providing just immense tensile strength.
But in someone with EDS...
In someone with EDS, that cross-linking is defective. The scaffolding is inherently disorganized. It's just weak.
So if a typical human body is a house built with solid steel beams, a hypermobile body is basically like trying to build that exact same house using rubber bands instead of steel.
That is a perfect analogy.
Everything is, technically held together, but it's loose, it shifts around under pressure, and it is fundamentally fragile.
Right. And because of those rubber band structural supports, hypermobile patients present with a really highly specific clinical profile.
Like what?
Well, they have this hyperextensible, doughy skin. They experience extreme tissue fragility, meaning capillaries burst easily, which results in severe bruising. And most importantly, for aesthetic medicine, they have notoriously poor wound healing.
Yeah, the clinical guidelines we pulled from the EDS clinic paint a pretty grim picture of traditional plastic surgery for this exact reason. Like, the sources talked about patients developing what they called cigarette paper scars.
Yeah, that's the clinical term for atrophic scarring. See, when a surgeon makes an incision, the body has to basically bridge that gap with new collagen during the healing process.
It's supposed to knit back together.
Right, it's supposed to weave together like a dense, tight basket. But with defective collagen, those tissue bridges are super weak. So as the skin just moves during normal daily activities, the wound slowly stretches horizontally.
Oh, wow.
Yeah, so you end up with a scar that is wide, it's depressed, and it's so thin you can actually see the underlying veins. It literally resembles the translucent paper wrapped around a cigarette.
That is wild. And it's not even just the healing process, right? It's the physical mechanics of the surgery itself. Like if you're getting a facelift,
Hmm.
the surgeon relies on pulling the connective tissue and anchoring it really tightly with sutures.
Exactly. But if your tissue is incredibly fragile, a tight, heavy suture basically acts like a Ching's wire.
Ugh, just slicing through.
Literally, the mechanical tension causes the thread to slice straight through the tissue,
Mm.
so surgeons see these alarmingly high rates of wound dehiscence.
Which is when the wound just pops open.
Yes, the surgical incision simply pops back open weeks after the procedure. I mean, to mitigate that, surgeons have to leave stitches in for double the normal time, use specialized taping techniques.
But the risk is still just massive.
Yeah, it's a huge risk.
So because scalpel surgery carries all those terrifying risks, the medical and aesthetic industries strongly suggest non-surgical alternatives for hypermobile patients.
Right, the prevailing wisdom is basically don't go under the knife, do something minimally invasive.
Yeah, like get dermal fillers or try a skin tightening laser. But that brings up the big question. How safe are those minimally invasive options when your body's structural framework is already so compromised?
Well, let's examine dermal fillers first,
Hmm.
specifically HA or hyaluronic acid fillers.
Okay.
When we review the dermatological abstracts from the EADV Congress, HA fillers are overwhelmingly categorized as the safest option for high-risk patients.
And I mean, the logic there makes sense on paper, right? Because they have an emergency eject button.
Exactly, they have an antidote.
Yeah, if an injection goes wrong, the practitioner can immediately inject an enzyme called hyaluronidase or Hylenex, which rapidly dissolves the synthetic filler within like 48 hours.
Right. And that chemical safety net provides a lot of comfort to practitioners. It really does. However, when we cross-reference that clinical confidence with the actual patient experiences on Reddit and EDS support forums,
The narrative just completely fragments.
completely.
It really does. I was reading through these patient anecdotes, and the behavior of the filler in these bodies is just wildly unpredictable.
It's all over the map.
Yeah. On one end of the spectrum, you have patients whose bodies metabolize the filler at warp speed. They pay for a lip filler, and a month later, their body has completely broken it down and absorbed it.
Money down the drain.
Exactly. And then on the other end of the spectrum, you have patients experiencing severe migration. Like they get filler in their cheeks, and 3 years later, it has slid down their face, pooling into these hard lumps near their jawline.
And what's fascinating here is the biological irony of the whole situation. Because hyaluronic acid isn't a foreign plastic, it is a naturally occurring molecule in the human body.
Right.
It acts as a vital shock absorber and a lubricant, specifically allowing the multiple layers of your fascia, which is the connective tissue web surrounding your muscles, to basically glide smoothly over one another.
So what happens to that natural HA in a body built with defective collagen?
Well, the mechanism breaks down entirely. In hypermobile EDS, the collagen scaffolding is just too weak to properly bind and support the body's natural HA molecules.
Oh, I see.
Yeah, so the body senses that the joints are loose and unstable, so it panics, right? It tries to compensate by overproducing hyaluronic acid to cushion the area.
But there's nowhere for it to go.
Exactly. Because there's no strong grid to attach to, this excess HA begins to superaggregate. It clumps together between the layers of the fascia.
So instead of acting like WD-40 for the muscles, it turns into this thick sludge.
Thick sludge is a great way to describe it. It becomes highly viscous and dense, and this causes severe fascial restrictions.
Ouch.
Yeah, the tissue layers literally get glued together, creating painful trigger points. This phenomenon is actually a primary driver of the chronic, widespread myofascial pain that EDS patients endure every single day.
Wow. So injecting more synthetic HA into that environment just seems like throwing a match into a powder keg.
It really does.
You're taking a system that is already drowning in dysregulated glue-like hyaluronic acid, and you are pumping concentrated cross-linked synthetic HA directly into it.
Right, and it perfectly explains the migration issues we see in the patient anecdotes.
Because it can't grip onto anything?
Exactly. The synthetic filler has no stable collagen framework to anchor itself to, so it just drifts through the fascial planes.
That is wild. And what about the metabolism issues? Why does it disappear so fast for some people?
That is likely tied to the comorbidities that frequently travel alongside EDS, most notably mast cell activation syndrome, or MCS.
Oh, right. The sources heavily emphasized MS gas. These patients have immune systems that are just constantly on high alert.
Yes. Mast cells are basically the sentinels of your immune system. They sit in your connective tissue just waiting to spot parasites or severe infections.
And when they spot something.
When they detect danger, they degranulate, meaning they literally burst open, releasing massive amounts of histamine and inflammatory cytokines to attack the invader.
Okay, so how does that work in someone with MSCAS?
In someone with MCS, those sentinels act like a broken car alarm. A leaf brushes the windshield and the alarm just blares at full volume.
So you inject a synthetic dermal filler, and even though it's supposed to be totally inert and safe, the broken car alarm goes off.
Bingo. The hyperreactive mast cells identify the filler as a catastrophic threat.
And the immune system just mounts a massive, localized attack on the face.
Exactly. This leads to prolonged inflammatory reactions, severe swelling, and hypersensitivity. We even saw reports in the EADV abstracts of delayed onset nodules.
Wait, what are those?
It's where the immune system suddenly decides to attack a filler that has been sitting peacefully in the face for 2 years.
2 years later?
Yeah. Usually triggered by something as simple as a mild viral infection or even seasonal allergies.
That is insane. And we haven't even touched on the anatomical risks, specifically for patients with vascular EDS or VEDS.
Right, VDS is a whole other ballgame. It's the rarest but absolutely the most dangerous subtype because the blood vessels themselves are structurally compromised.
And one of the risks of fillers is vascular occlusion, right?
Yes. One of the rare but catastrophic risks of dermal fillers in the general population is vascular occlusion. I mean, the face is a dense highway of arteries. If the needle accidentally pierces an artery and deposits that thick filler inside the vessel, it creates a literal roadblock. Blood cannot get past it.
So the tissue downstream from that block is instantly starved of oxygen and basically begins to die.
Exactly, tissue necrosis. Now, in a typical patient, the emergency protocol is to flood the area with Hylenix to dissolve the block before the tissue dies.
What for vascular EDS?
In a patient with vascular EDS, the walls of those arteries are as fragile as wet tissue paper. So the mechanical trauma of the needle, combined with the pressure of the filler being forced into the vessel,
Oh, no.
yeah, it can cause the artery to simply rupture.
So while HA fillers technically have an undo button, utilizing them in a hypermobile body is essentially a biological roll of the dice,
It really is.
which naturally leads us to the other major non-surgical option that is being heavily marketed right now, energy-based devices, or EBDs. These are your fractional CO2 lasers and radiofrequency microneedling devices.
And EBDs just dominate the aesthetic market right now. They are used for facial skin tightening, vaginal rejuvenation, and even arthroscopic treatments for joint pain.
But we need to be incredibly clear about how they actually work, because they don't add physical volume to the face like a filler does.
No, completely different mechanism.
EBDs work by inducing controlled thermal damage. Like a fractional CO2 laser basically blasts microscopic columns of intense heat deep into the dermis.
It literally vaporizes tiny pillars of tissue.
Right. And then the body registers this severe thermal injury, hits the panic button, and rushes to heal the burns by producing brand new, tighter collagen.
Exactly. You are intentionally injuring the tissue to force the body's repair mechanisms to rebuild it stronger.
And here's where it gets really interesting for me. Because what does this all mean for EDS? The whole marketing pitch is stimulates collagen production. But if we connect this to the bigger picture of hypermobility, the patient's collagen factory is fundamentally broken at the genetic level.
Right.
So if the factory only produces defective, weak materials, why would we purposefully burn the tissue just to force the factory to make more broken materials?
It's a fantastic question, and the clinical data validates that exact concern. The FDA actually issued a really highly unusual and strict safety communication regarding EBDs.
I saw that in the sources. It was specifically targeting devices marketed for vaginal rejuvenation, right?
Yes. Those lasers are heavily marketed to treat vaginal laxity and menopausal dryness by basically tightening the tissue.
And what did the FDA say?
The FDA warned that the thermal damage from these devices has caused severe, irreversible complications in a subset of women. We're talking about severe vaginal burns, thick, atrophic scarring, and recurring chronic pain caused by the tightened, damaged tissue.
Wow. And if an ablative laser is causing severe burns and scarring in the general population.
Think about the EDS population.
Exactly. For someone whose skin is already incredibly fragile and prone to abnormal wound healing, the risk must be astronomical.
It is, and the thermal risks extend beyond just the skin. We also analyze sources discussing arthroscopic radiofrequency, which is used for joint stabilization.
Oh, right, for loose joints.
Yeah, orthopedic surgeons will sometimes use these heat wands inside a loose joint to shrink the connective tissue.
But there are risks there too.
Huge risks. The theoretical adverse events listed in the literature include excessive debridement of articular cartilage and chondrocyte death.
Meaning the heat is so intense it literally permanently kills the cartilage cells inside the joint.
Yes. And for an EDS patient whose joints are already unstable and grinding against each other, inflicting thermal damage on the remaining cartilage is just playing with fire.
But wait, I hit a massive wall in our research stack right here.
Oh,
Yeah, because on one side of my desk, I have this blaring FDA safety communication warning that lasers cause severe, irreversible thermal burns. But on the other side, I have clinical protocols from a physical therapy clinic that specializes in EDS.
yes.
And they are raving about lasers. They state lasers are a primary tool for melting away EDS pain and muscle spasms. It makes zero sense. Are lasers destroying hypermobile tissue or saving it?
I'm so glad you brought this up, because this raises a really important question about the umbrella terminology we use in medicine.
Okay.
Laser simply means light amplification by stimulated emission of radiation. That's it. The actual mechanism of action changes entirely depending on the wavelength and the intensity.
So we are basically comparing two completely different tools that just happen to share the same name.
Exactly, we are. The fractional CO2 lasers that are causing burns are ablative lasers. They use water-absorbing wavelength that instantly boil the water inside the cells, which vaporizes the tissue.
Okay, and what is the physical therapy clinic using?
They are using class 4 low-level lasers, which is a form of photobiomodulation.
Photobiomodulation. Let's break down how that actually interacts with a hypermobile body.
Sure. So when a hypermobile joint is loose, the surrounding muscles basically have to work overtime to hold the skeleton together.
Because the ligaments aren't doing their job.
Right. So the muscles lock up in these chronic, agonizing spasms. Now, to physically release a muscle spasm, your body actually requires a massive amount of cellular energy, or ATP, to get the muscle fibers to let go of their contraction.
It takes energy to relax.
Exactly. But because the muscle is tight, blood flow is restricted, oxygen drops, and ATP production basically stalls out. So the muscle gets physically locked in a spasm.
It runs out of gas while the pedal is pushed to the floor.
That is the perfect way to put it. Now, class 4 lasers penetrate deep into the tissue and bypass that bottleneck entirely,
Ow.
because the specific wavelengths of light do not generate destructive heat. Instead, the light particles are absorbed directly by the mitochondria inside your cells, which stimulates them to churn out massive amounts of ATP.
Oh, wow.
Yeah, it gives the muscle the exact energy currency it needs to finally unlock and relax, completely without stretching or burning the fragile connective tissue.
That is an incredible mechanism. It's
Yeah.
really the difference between using a laser as like a microscopic blowtorch to burn things versus using a laser as a flashlight to give the mitochondria a direct energy boost.
Exactly, which really highlights why making blanket statements about lasers being safe or dangerous for hypermobility is fundamentally unhelpful. You have to look at the actual cellular mechanism of action.
Okay, so we have all this information on the table now. We have the unpredictable metabolism and migration of HA fillers, the MCAS immune reactions.
The catastrophic thermal dangers of ablative EBDs.
Right. And the healing potential of photobiomodulation. It is time to synthesize this into a final verdict. When we put them head-to-head, which non-surgical option is actually safer for a hypermobile patient?
Well, the hard truth is that neither option is completely safe, but their risk profiles operate on totally different levels of permanence.
Meaning?
With HA fillers, you carry the risks of unpredictable longevity, severe fascial migration, and MCS-driven immune flares. But you retain the undo button.
The Hylex.
Right. If an inflammatory cascade begins or the filler migrates, a skilled practitioner can inject hyaluronidase to dissolve the material and halt the reaction.
So it's not a magic wand, but it is a viable exit strategy.
Yes. Whereas with energy-based devices that rely on heat,
The ablative ones.
right, with thermal EBDs, you carry the risk of irreversible thermal burns. If an ablative laser triggers a massive abnormal scarring response in an EDS patient, or if a radiofrequency device damages the underlying cartilage,
There's no enzyme you can inject to undo a burn.
exactly, the structural damage to the already fragile tissue is permanent.
Wow. Yet, despite all of these compounding risks, the official guidelines for facial plastic surgery in EDS patients still maintain that non-surgical treatments are preferable.
Which really speaks volumes about just how catastrophic traditional scalpel surgery is for this population.
Yeah.
Given the choice between a scalpel slicing open tissue that is guaranteed to struggle with wound healing versus carefully selected filler injections or non-ablative therapies, the non-surgical route still statistically wins out on overall safety.
Which brings us to the ultimate takeaway for you listening right now. If you or someone you know has hypermobility, the safety factor isn't just the syringe or the laser being used.
No, not at all.
It is the practitioner holding the tool.
Yeah.
You cannot just walk into a strip mall med spa, point to a menu of services, and assume the injector understands the biomechanics of Ehlers-Danlos syndrome.
The sources universally emphasize the necessity of disclosing your condition. You have to ensure the provider deeply understands connective tissue disorders. Based on the mechanisms we've discussed, patients might want to heavily prioritize treatments that have a chemical safety net, like HA fillers, or treatments that heal without destroying tissue in the first place, like class 4 photobiomodulation.
It is entirely about mitigating risk in a body that fundamentally refuses to follow the normal rules of healing. I mean, instead of treating filler like a simple cosmetic touch-up, think about the physics of it.
The structural physics.
Exactly. Injecting filler into a hypermobile face is basically more like pouring wet cement into a wall frame that doesn't have any rebar.
That's a great visual.
Right. The framework is just too loose to support it, so the cement just pools at the bottom, hardens in the wrong places, and ultimately weighs the whole fragile structure down.
You have to work with your body's unique architectural blueprint, not fight against it.
Absolutely. So to summarize our deep dive today, navigating aesthetic and medical treatments with a hypermobile body requires an incredible amount of caution. Dermal fillers can trigger severe immune responses and migrate unpredictably through unsupported fascia, while energy devices that rely on burning tissue to stimulate collagen can leave irreversible scarring if they aren't perfectly calibrated for fragile skin.
It is a really delicate, highly individualized balance.
It really is. But before we sign off, there is one final lingering question we want to leave you with to ponder on your own.
Well, what's that?
Well, the entire global anti-aging industry, which is worth billions of dollars, is currently completely obsessed with stimulating collagen as the ultimate fountain of youth.
Burn it, poke it, stretch it, just force the body to make more collagen.
Exactly. But as diagnostic awareness of hypermobility spectrum disorders grows, and we realize a massive percentage of the population actually has a mutated, defective collagen blueprint,
Right.
will the cosmetic industry eventually be forced to invent entirely new ways to rejuvenate the human body? Like ways that don't rely on collagen at all?
Now, that is a paradigm shift the industry really isn't prepared for yet.
Definitely not. So next time you see an ad promising to boost your collagen, just remember, if your house is built with rubber bands, adding more rubber bands might not be the fix you're looking for.